The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Welcome to this ASCO in Action podcast. This is ASCO's monthly podcast series that explores policy and practice issues with impact on oncologists, the entire cancer care delivery team, and most importantly, the individuals we care for, people with cancer. My name is Cliff Hudis, and I'm the CEO of ASCO, as well as the host of the ASCO in Action podcast series. For today's podcast, I'm really excited to have as my guest ASCO's own Vice President of Clinical Affairs, Dr. Stephen Grubbs. Before coming to ASCO, Dr. Grubbs worked as a community oncologist and the managing partner at Medical Oncology Hematology Consultants, PA, in Newark, Delaware. Dr. Grubbs has been an active ASCO volunteer, and he was the principal investigator of the Delaware Christiana Care National Cancer Institute Community Oncology Research Program before he came to ASCO. He also serves on the advisory council of the Delaware Cancer Consortium, of which he's been a member since 2003. Our conversation today is going to focus on the Quality Payment Program known as QPP, and our goal is to illuminate what oncology providers and practices need to know and what they have to do to successfully participate in this program for 2018. The Quality Payment Program, or QPP, was established by the Medicare Access and CHIP Reauthorization Act of 2015, generally known as MACRA. And it is transforming the way that physicians are reimbursed for the services they provide under Medicare Part B. Program implementation began last year, and while 2018 can be seen as a second transition year, the requirements for demonstrating and reporting quality improvement, appropriate use of technology, and prudent use of resources are heavier this year than they were last year. So it's important that everybody understand the changes that they have to address to avoid financial penalties potentially in 2020. With that, I want to welcome Dr. Grubbs and thank you for joining me today. Let's just set the stage here a bit. Give me your elevator pitch on how MACRA and subsequently the Quality Payment Program are transforming physician reimbursement.
Sure. The Quality Payment Program is really the government's attempt to really rapidly transfer physicians from a volume-based payment program to a value-based program. And there are some that believe this is the biggest change in reimbursement in medicine since the onset of Medicare back in the 1960s. So this new program, there's publications from CMS that says they would like to see at least 50% of all their payments in alternative payment models in the future, and this program is set up to transition physicians into alternative payment models eventually.
So, Steve, you already introduced another acronym here, APMs. Can you just remind everybody what is an APM?
Right. It's an alternative payment model, and it's the considered solution to get physicians into value systems where they actually take on some of the financial risk of caring for patients and yet provide better quality.
I see. So, backing up again, here in 2018, I understand that we're in the middle of a multi-year implementation process. Exactly where are we in this process? How many years long will it be? What are the steps that everybody should be anticipating?
Well, I think the first thing to know is the timeline in the program. Most physicians are in the merit-based incentive payment program called MIPS. And the timeline chronologically for that is the year you actually perform, which, and I'll use this year as the example, 2018, will be measured by CMS in 2019. And then in 2020, a potential adjustment will be made to your Medicare fee schedule. So if we actually back up 1 year, this whole program began last year. 2017 was the first performance year. That now they will be evaluating this year your scores you received in the MIPS program, and that will affect your payments potentially in 2019.
Okay, and you said most physicians are covered by MIPS this year. Can you just clarify? We have a wide range of ASCO members. Which kinds of practice settings are most clearly engaged in this? And by the way, which practices or settings are engaged, but maybe the members don't realize it?
So first of all, in the system, you can be reporting either as an individual physician or as a group. And it appears that most people will want to be in group reporting. There's complications when you begin to do it individually. You may not have enough volume of patients to report on, number one, as an individual. And number two, the potential, as I saw it having run a practice before, is I could end up with different fee schedules for different doctors, which would make our billing system very complex. But having said that, all physicians that report in Part B are required to be in this system and do reporting. If you're in a special alternative payment model, you're exempt from the MIPS program, and we can talk about that later. But let's concentrate on MIPS because really 100% of oncologists are really in that right now. If you're in an independent practice, you really need to know how to do this because you are required to report as an independent practice. If you're in a multi-specialty practice as an oncologist, you probably don't need to think so much about this right now because your multi-specialty practice will be reporting data that is most likely coming from your primary care physicians, and you'll be brought along with the score that they get. Having said that, in the future, there's the possibility that the specialists will be broken out of the multi-specialty group, so it's important for everybody to know about this system right now.
And what about the large chunk of ASCO members in traditional academic practice? Just to be clear, how does this affect them?
They're mostly at large hospital-based or university-based programs that are multi-specialty. So they're really going to be covered by their multi-specialty group. And as I said, don't need to think so much about it today, but you should learn about it because I expect someday they will be reporting independently.
Right. So the point is, this is just a way of illustrating that it affects everybody, whether they know it or not.
Sure.
Okay. And so what exactly, you started to touch on this, do the people who are, the physicians who are actually engaged in this already fully, what do they have to do that's different in 2018 as opposed to 2017?
So we concentrate on the merit incentive-based payment system. You will get a score every year for you or your practice, depending on how you report, anywhere from 0 points to 100 points. And when you get your scale of points, it will be compared to all other physicians in the United States. And if you're on the low end of the scale, you'll receive a penalty on your fee schedule 2 years later. Or if you're on the upper end, you'll actually have a positive adjustment. And again, the way CMS works is every year they publish the fee schedule for the next year, and then you individually will have some adjustment up or down or neutral based on your score that you get. So what's important is in 2017, last year, what we did, CMS made it a transition year to get people into the system. And they had a minimal requirement to stay out of trouble, not to lose the penalty. The penalty last year, if you didn't do well, was minus 4% off your 2019 fee schedule. This year, it's going to be minus 5% or plus 5% off your 2020 schedule. And by several years later, that will increase to minus 9 or plus 9. So this is a graduated scale up, and the penalties will get higher, but the potential benefits could get higher too. It is revenue neutral. The money that's taken away from those that are at the end of the bottom of the scale will be given to those at the top of the scale. So it's a zero-sum game in terms of Medicare payments. 2018, however, is still a transition year, but it's more rigorous than 2017. Last year, all you had to do was report on one quality metric on one patient or do some practice improvement activity. This year, you have to do much more work. And in the scale of 0 to 100, last year, if all you had was 3 points, you wouldn't get a penalty. This year, it's 15 points. So that means you must report, say, on 5 or 6 quality metrics and get a certain amount of points to get there. Next year, we anticipate it will be a full-blown requirement.
So just to back up and focus on this revenue neutrality, and people will probably wonder about that, it implies that every reward is matched by a penalty for somebody. And so ultimately, it isn't about getting over an arbitrary line. It's about where you are relative to your peers, and it's a way of forcing everybody to march up. But it guarantees that some people are going to bear a financial hit, right?
So I think if you really project out over the years, I think what you'll see is those at the bottom of the list that are taking penalties on will drop out and go elsewhere. So that group that pays a penalty will gradually march up the scale. So why is that going to happen? Because CMS really wants us in alternative payment models. They don't want us in this MIPS system. They want us in this. This is going to be a system with increasing penalties and people dropping out and then the scale moving up to probably push all of us into alternative payment models.
So that's a perfect segue to my next question, which is I understand that there are so-called advanced alternative payment models and that they provide an opportunity for participants to do as you just said, which is opt out of the MIPS program. But there are also APMs that are not advanced because the financial risk or other program requirements that they follow. Can you just clarify APM, advanced APM, and what this really means?
So an alternative payment model means that physicians are being paid based on quality metrics or even some financial risk that they take in it. And there are all kinds of different levels of alternative payment models going up to population medicine where you get a per member per month payment to do everything for the whole population. So CMS has defined an advanced alternative payment model, which if you are in that, you are exempt from MIPS. And an advanced alternative payment model is defined as one that uses a certified electronic health record, has quality metrics at least equal to or more rigorous than in the MIPS system. And number 3, takes on two-sided financial risk, meaning the practice or the physician can have an upside gain, or if they don't do well in cost, they'll have a negative money taken back. And then the other part of that is to be in an alternative payment model, an advanced one that would qualify you to get out of MIPS, you have to have a certain volume of your patients going through that. And in 2019, the first year that this all kicks in, you require 20% of your Medicare patients to be paid through this advanced alternative payment model, or 25% of your Medicare revenue. That will go up in subsequent years. Now, if you're in the advanced alternative payment model and out of MIPS, you'll get the reward or benefit or the potential loss of the alternative payment model, but you'll also get a 5% bonus from CMS for all your revenue that year. So again, the incentives are there to push us out of MIPS and get us into these alternative payment models. Now, alternative payment models that don't meet all that criteria still are recognized by CMS, and will be in MIPS then, but you'll get some special considerations on your MIPS score by being in the alternative payment model that's the non-advanced one.
So it sounds like practices, unfortunately, have to continue to make special investments in management of all of this, right?
Right. So I think the answer on that is one needs to have a transformation of your practice to be able to do well both in MIPS or in the alternative payment model. You have to be doing practice improvement. You have to learn how to do that. You have to demonstrate that in either of those systems. You have to be carefully monitoring your quality metrics and make sure that they're improving over time. And you have to begin to look at, are you containing costs?
And this reminds me, of course, ASCO has some resources that we're able to bring to bear to assist practices.
Sure.
In this, right?
Yeah, absolutely. Well, first of all, ASCO developed its own idea of a good oncology alternative payment model, the patient-centered oncology payment model that was published in 2015. And as we've worked with that, it became very clear that you need to have a change in infrastructure to make either that or any other alternative payment model work. So in response to that, ASCO in the last 12 months has started its first consulting program where we have consultants that will come to your practice and do what we call a readiness assessment evaluation that looks for gaps in how you're practicing that were required to make any of these systems to work properly. Then we're able to come back if needed and actually do consultation to help you realign what you're doing in your practice. And the third thing is we're promoting practices looking at that triage pathway systems, because triage pathway systems have shown that you will keep your patients out of the emergency room and out of the hospital, which in the end is one of the biggest cost savers that you can do to contain costs.
So I'm just curious, we make the point in all of this that ultimately it's about the patient. How, if at all, would an individual patient perceive that their doctor's practice was enmeshed in all of this right now?
Well, I think one of the things that's going to happen is once these quality data are obtained and your MIPS scores are calculated, ASCO or the CMS will start publishing those. So that hasn't happened yet, but on Physician Compare, which is their site where you can look at any physician right now and find out about them, you'll eventually see these scores and quality metric evaluations show up there. Having said that, I think the patients will recognize if they're in an alternative payment model, because those models require certain specific things like patient navigation and other items that I think they'll see an upgrade in perhaps their care.
So there are, underneath all of this, there are clear indicators to the patient that what they're getting should be a higher quality product in the end, if you will.
That's what's expected out of this. And I think that's the important thing that physicians are learning now, is they have to report on quality and other parts of their practice that should show up as a better care for the patient.
Okay. And do the next few years, if you're in the APM, look the way you described it in MIPS in terms of the timeline for financial impact and assessment, or is the timeline different in the APM?
No, the APM is the same timeline. Your all adjustments and payments will begin in this system in 2019. And if you're in the right APM, you'll get a 5% bonus. If you're in MIPS, you'll get the plus or minus depending on your score. So everybody starts at the same time with adjustments and payments through this.
Okay. And are there any other special considerations that practices that are participating in the oncology care model or other alternative payment models like accountable care organizations have to make? Is there anything we've not covered there?
Well, I think for oncologists, the important thing is the oncology care model, which is the Center of Medicare and Medicaid Innovation. Their first attempt to put a alternative payment model specifically for oncology. And there's about, I think, 190 practices in the United States that are participating in that. If you're in the oncology care model, you have the option of staying in what's an upside gain only or a two-sided risk where you could actually lose money. If you're in the two-sided risk option, if you choose that, that's an advanced alternative payment model, and therefore you would be out of MIPS. To date, none of the practices have chosen that yet. So that's now, if you're in this one, though, and it's not the two-sided risk, you do get special considerations. First of all, your quality metrics do not have to be put through MIPS. You'll get those through the OCM. And practice improvement activities are considered part of the OCM, so you don't have to do anything special for that. And we really didn't talk about that. The scores in the MIPS system are 50% this year for quality, 25% for how you use your electronic health record, 10% on cost, which is new this year, and the 15% for practice improvement.
What does it mean about the next couple of years that nobody's opted in to the two-sided risk, if I heard you correctly? Do they need to make adjustments in that program? It seems like the market is speaking in the sense that they're not choosing that yet. Well,
the first thing is I don't think they've seen their reports yet on how each practice has done compared to what CMS is going to calculate what their cost should have been. So I think they're waiting to see how that is because, again, if they're under the cost and they were in two-sided risk, they would pay a penalty. It's yet to be seen how many of those will go into the two-sided risk. The OCM program is a 5-year pilot, and it'll be, 2 years old this summer. So it's got 3 more years to play out. And again, I think everybody has to really look at pilots. These APMs is real pilots right now because we really don't know how they're going to turn out.
And just as an aside, this raises always the question of politics. And without getting into that in any specific way, how fixed is this course ahead, or do you think it's subject to political variation, meaning because of the political debates, do you think that it could change direction?
I think the direction of putting us into value-based systems is set. I don't think that's going to change. I think the level that we're going to be in these systems is open to question. Because, again, I really do think a lot of these alternative payment models are all speculative right now until we really get the data. Are they working or not working, and are they causing a disruption in the medical care? I don't think until we know that, you'll know exactly where we're going to end up on this.
So I noticed you use the plural for APMs. How many of these alternative payment models are there actually? How many might our listeners be selecting from?
Well, right now, I think CMS has 10 advanced alternative payment models that they've designated. The majority of them are primary care models, and the majority of the payments coming from CMS through APMs are primary care physicians. There is one for chronic renal disease, there is one for orthopedic surgery, and then there is the oncology care model in oncology. Now, this is going on outside of CMS. We've concentrated today on MACRA and then the QPP program that came out of it, the private insurers are all looking at alternative payment models, and they're actually participating in the oncology care model also. So I know we've had discussions with our alternative payment model with private commercial insurers of the ideas we have there that they might want to implement. And actually, one practice in New Mexico has our ASCO alternative payment model running. That's now 2 years into action, waiting to see the data.
And so, just to be really clear, though, in the domain of oncology where we're addressing, how many APMs are there actually available for an ASCO member to be selecting?
Outside of the oncology care model, the two-sided risk, there are no advanced alternative payment models to pick from today.
So I know I'm being somewhat picky in here, but so what it really means is in the domain of oncology, there's really one APM, which is the oncology care model for 2018. Is that a fair assessment?
I think that's a fair assessment.
Okay, great. That's wonderful. So backing up a little bit, now that we've gone through all of this, I wonder if you could just explain how some of the other efforts that ASCO's been working on fit into this system. For example, COPI reporting registry. How is that helping oncology practices in terms of reporting, and how does that relate to MIPS?
Sure. So the important thing for the practices that are MIPS is learning to report and report properly, because you're going to be in trouble if you don't do that. So we set out with our Quality Oncology Practice Improvement Initiative, COPI, to develop a reporting registry. Now, CMS has to deem that your registry is capable of reporting properly, and that's called a qualified registry with them. And ASCO has that. So what we've done in the last, year and a half is we've taken our registry and we've developed it so we can electronically report for practices no matter what electronic health system you have. And our QCDR, Qualified Data Registry, can report your quality metrics, it can report your practice improvement activities, and it can report your electronic health record use. So we're capable of doing 100% reporting for you. The cost measures are calculated by CMS. But those other three areas we can fully report for you in 2018.
All right, great. So that's one more of the assets that we've tried to bring to bear here. What's your assessment as VP for Clinical Affairs? You hear, I think, from practices all over the country. This is, in a sense, a two-part question, which is how prepared do you think that the practices are? How effective do you think our own education and advocacy efforts have been to support the practices? What do we need to do to help people thrive in this new world?
I think the key issue here is making sure that the business leaders of the practices are aware of this, and we've really concentrated on reaching out to practice administrators and hospital practice administrators to make sure they're knowledgeable. And usually there's one physician that's a managing type partner in a practice that should be knowledgeable in this too. So we've had a number of webinars that have been highly attended mainly by practice administrators, and we've certainly been giving presentations at the oncology societies around the United States. Now, it's interesting. I just gave a talk on this weekend out in California with about 350 physicians who were practicing oncologists. And I asked them the question with one of those audience response things, and the answer came back that a third of them didn't know about MIPS, a third of them had a little bit of an idea, and a third of them felt pretty comfortable with it. But that is not necessarily bad as long as their practice administrator knows it. And I think most of the practice administrators are getting pretty wise on this. And again, they've been our target.
So for those people, that surprising number who actually said they weren't really familiar with this yet, and this is my last formal question for today, where's the place that you would direct them to start? What's the first stop in their quest to understand this and start to be ready?
So at ASCO on our website, we have a tremendous amount of information on MACRA and then the QPP. So if they go to the website, which is asco.org/MACRA, M-A-C-R-A, they can get all the resources we have there. And we have interesting things there, like we have the top 10 list each year of what you should be doing in your practice to get ready to be successful in this. We actually have scenarios where by doing one activity, you can get multiple points to make, more bang for your buck for what you do there. And the other part that we really didn't talk about is CMS has deemed our QPP certification program and our quality training program to suffice for getting your practice improvement points. So all those things, and we've made a big list of things you can do in QPP or QPP certification or QTP, quality training program, to get your practice improvement points. And actually, you can take them right off the shelf and do them. So we've tried to make this as seamless and as easy for everybody to get a high score.
I think that's great. I think one of the challenges clearly is that most oncologists who went through training and went into practice really weren't thinking about this kind of management. And now they have to understand it and they have to excel at it ultimately. And what we're trying to do here is make sure they have all the resources that they need. So I think all the members and I really appreciate the effort that you've put in to driving us to clarity on what is needed and also standing up the resources to help people succeed. So with that, I want to first thank you, Dr. Grubbs, for joining me today for this ASCO in Action podcast.
My pleasure. I think this is one of the most important things ASCO has done in the last 2 years to help our membership, because this is a paradigm shift in how we're going to practice.
Yeah, it sounds like it really is. And I think that the point that it affects everybody, whether they know it or not, is something that will resonate for years to come with listeners and all of our members. So if you would like to learn more about the Quality Payment Program, you can visit the website Steve referred to before, which is asco.org/MACRA. That's MACRA. And if you go there, you'll see tools, resources, and webinars, as Steve just discussed. They're all available to you to successfully implement in 2018 the quality payment program changes that your practice needs to make. I think it's also fair to say that people can contact you directly. There are a number of consultative services and advice that you can get directly from Clinical Affairs at ASCO to help with this. So with that, until next time, I want to thank everybody for listening to this ASCO in Action podcast.